Richard is going to come in next. Richard is a consultant nephrologist at the Hammersmith Hospital and has done a lot of work both nationally and internationally around ferritin dialysis, being part of the ISPD work, and does a lot of teaching for our trainees as well around home dialysis as part of the PD Academy course. And he's going to talk to us about the work they have been doing in London. And thanks, Richard, for joining us.
Thanks, Uday. Thank you for the opportunity. We've had some fantastic discussion about quality improvement this morning, and I think everybody in this room believes in the role of quality improvement and the role of home dialysis in looking after and trying to improve the lives of people living with kidney disease. But I want to take the story I'm going to tell about how we may be approaching it in London is slightly different, and I think comes from some of those questions about we're trying to hang it on a slightly different story here. And I'm presenting on behalf of Suzanne Forbes and I, who co-chair the dialysis workstream within the London Kidney Network. I think in this room we've got many people. We've got some people with lived experience. We've got charities. We've got commercial supporters, providers, commercial partners, and we've got clearly doctors and clinicians, nurses, and maybe other individuals from renal units. But I think we must not forget that there are all these partners need to come together to work effectively to really drive the change that we want to see. Each of these groups has a role to play in trying to support the growth in home dialysis. And I think, as Uday's trailed heavily, is that one of the things I want to come out of this talk today is about how we think about ICBs and commissioners, how we promote kidney services and really try and mitigate the demand for growth in home-based dialysis. I'm going to start, we're talking a little bit about the quality improvement work we're trying to support in London, but I'm going to be talking a little bit more around some of that bigger piece of work. The graph on the left shows how dialysis at home has continued to grow over the last decade in London. That's a combination of PD and home hemodialysis, and there has been a continued growth. There's a significant uptake here, which we will all recognise from the many units we work or are associated with, which relates to the COVID pandemic and a choice for many people to go home to try to dialyse at home. And then I think, sadly, many of us hoped that growth would be sustained, and then we saw a fall back, or perhaps this is a statistical phenomenon, a regression to the mean. Perhaps it's a representation of the workforce, and I think many nursing teams who were delivering PD during that time felt that the workforce was not appropriately supported to continue that growth. And some of that is transplantation that happened post-COVID to catch up with that. But despite that, in London, we've seen a continued growth in line with the trajectory over the previous decade. And yet, when we look at the GIRF to 20% target, we see that our percentage of the home dialysis population in London has actually fallen as part of the total dialysis population. And that is mainly because our growth in home dialysis has rocketed in London, as it has in many other centres. Just a bit about what the London Kidney Network is. We are one of the NHS England supported regional kidney networks. We support 20% of the renal activity in the UK, in England, apologies, with over 10 million people, including around 6,500 to 7,000 people on dialysis, both in centre and home hemodialysis. And we're not just the London Kidney Network, we also support Surrey Heartlands as well. And we're made up of 7 kidney units, which many of you will recognise, but also key partners within this are the integrated care systems and integrated care boards, who provide both responsibility for oversight of primary care as well as some of the commissioning that we are in the unit involved with. I think we all recognise that there is a growing demand for hemodialysis. And apologies, this slide is already out of date and I think sits behind probably where we see this going. But essentially, between now and 2030, depending on what modelling scenario you use, we expect somewhere between 780 and nearly 2,000 more people to require renal replacement therapy or dialysis support in that period of time. If we go for a middle ground estimate of growth, that means we're looking at around 1,400 patients. That is in keeping with the Hammersmith Imperial College Healthcare Trust, a size of the renal unit. That is the current population we support at the moment. We're talking about another unit in London size population required to support the number of people on dialysis, with the cost that goes with that. And that is a significant cost for the healthcare system in general. And it's on that basis that we really need to think about, we're trying to create the story about why we need to mitigate that demand for in-centre capacity through the growth of home hemodialysis. Hopefully the kidney dialysis occupancy measure is not a stranger to many of you in the room. For those of you who have not been familiar with it, this is something that Stephen Casson, our business BI lead, Peter Wilson, have developed and led on from London. I think is now adopted and supported across the kidney networks across England. And this is really looking at both state capacity, but staffing capacity for in-centre haemodialysis. And you can see this amber sign, which is where we think that units are over 90%. We think that is a danger sign, but you can see that clearly in parts of London, we are already over in the red, unable to effectively support. Well, I think we are working hard to support people on in-centre haemodialysis in London already. So essentially, whatever our growth looks like going over the next 5, 6, 10 years, we are already struggling with both estate and staffing capacity for in-centre haemodialysis. And it therefore is clear why we need to be thinking about growing the access to dialysis at home, regardless of all the other great reasons that we know dialysis at home makes sense for people living with kidney disease. Okay, and this is about trying to make that broader financial case. I think one of the ways we've also framed it is around the health equity issue. I think somebody touched on inequalities and access to PD and home haemodialysis. In London, the greatest health inequality in around this depends upon the centre that you dialyse in, not your age, not ethnicity, not social deprivation. We know from Catherine Croucher's work with her health equity baseline assessment that there is significant inter-unit variation around your access to home dialysis. And that is both in the incident population, the number of people starting on dialysis, but also on the prevalent population with some units, as we know, around 10% of the prevalent population. And that's sadly within London, not many of us making the 20% target. And I think it's just worth reflecting on one, without going into too many quality improvement discussions, it's worth just reflecting on a couple of case stories about successes in London over the last decade. This is West London, Imperial. And I think what we've seen over the last decade is a growth in the population from 60 to almost over at its apex, around 220 people doing PD in West London. But that was essentially driven by commissioner requirements to ensure that there was equitable access to home dialysis for people living in northwest London. It required some of those quality improvement processes we've discussed about. It required enthusiasm, both from home dialysis clinical leadership and nursing teams, but it also required operational prioritisation and oversight. It required engaged surgeons and interventionologists, empowered and engaged nursing teams in both an AKCC and an overall cultural change. But despite this, as you can see, that though we've seen a growth, that dialysis growth has continued, that though we've continued to start large numbers of people on PD, growth has tailed off. And that is in part, as I think we've seen from a number of those growth charts already this morning, is because significant work is required to get people onto dialysis and keep them on dialysis. And we'll talk a bit more about why that what that looks like in terms of some modelling numbers in a moment. Equally, in Barts, which is I think the only unit in London which has always had a history of getting large numbers of people onto PD and has done very well. They have focused on growing their home haemodialysis growth, but equally you can see that their home haemodialysis rates, despite significant amounts of quality improvement work, have started to plateau, and that is partly because, again, reflecting some of the challenges associated with the growth and demand for in-centre haemodialysis and the structural problems in terms of ensuring resources in place to support continued growth for home dialysis programmes. And so what we are trying to do is use a modelling approach to really try and provide some operational insight. And we're calling this GRIP 33. Whether you want to think about this, about giving a grip on home dialysis, but it relates to the idea of what we want to be trying to do is moving this conversation towards the growing instant peritoneal dialysis to 33%. We'll talk about peritoneal dialysis, but home haemodialysis. That's not to move away from that 20% discussion within that room. And I think outside this room, that 20% target from getting the GIRF process is helpful externally, but I want to perhaps just think about how we might reframe this to a 33% incident rate for a number of reasons. And the reason we've come up with a small modelling toolkit to allow this is to support units in testing their models of prevalent dialysis growth against a London Kidney Network model of demand and capacity, really trying to think about what the numbers of people in London are going to look like in the next 5-10 years. And actually, are units' predictions around growth and home dialysis realistic? And then, because most of us who work in this room know how much work is required at the start of the patient journey on home dialysis, the catheter placement, the dialysis access, fluid installation, the training, actually think about the resource implications required to support that and support people, particularly with ensuring we've got adequately trained workforce over the next 10 years. And this, I don't expect you to look at the detail, but this is essentially based upon a wider piece of work around demand and capacity modelling in London around dialysis needs, not looking just at the next year, not looking at 3 years, but looking at 10 years and thinking about how we mitigate that demand for in-centre haemodialysis by ensuring that we've got the resource and units are resourced appropriately to think about growing their home dialysis populations in a sustainable manner. So this, there are a number of different calculators around, and I know that Marie and Mark have led very much with the commissioning support units to think about some really powerful calculators. This is a fairly sort of ballpark attempt to just try and help test some of these modelling numbers. And what we can do is within this model is allows units to estimate their local growth, look at a starting prevalent dialysis population, but also input what their average time on in-centre haemodialysis is and the average time on a home therapy is. The challenge with the GIRF 20% is if you're delivering really good in-centre haemodialysis care, actually time on in-centre haemodialysis is substantially longer than the time on PD for a number of different reasons. And therefore, if you're providing really good in-centre haemodialysis care, this number may appear bigger, and your prevalent PD population, even if you're doing the right things, getting people transplanted early, is always going to be a challenge. It allows us to also think about the incident population, and what we've asked units to do is put into this calculator their models of growth, which are often, if I'm being honest, have been straight line projections. Within this modelling tool, it allows then units to interrogate both what their unit prediction is and allows them to play with different incident populations and different take-on rates, and actually, by changing their peritonitis rate, how it might impact on their time on dialysis and keep people on dialysis for longer. Peritonitis is a problem, and we must acknowledge that. We'll come to that in a moment. But if I can show you here what this might look like for one unit, if we wanted to continue to grow, for instance, this population to grow from 220 patients on PD to 322 over the next decade, this would mean doubling your incident. So there's only a 50% growth in your home dialysis population. This would mean requirement of growing your incident population from 7 starts a month to 14 dialysis starts per month. So that has a significant resource implication, but it also allows people to look at a month-by-month basis to think about, are we really achieving what we need to do, rather than 3 years down the line with a quality improvement process going, our rate is still only at 17%. Are we starting 14 people every month onto home dialysis and keeping them there? But I would also point out that even doing this, even with that growth of 50% in the prevalent dialysis population over the next 10 years, that GIRF 20% is not going to be achieved despite all that significant work that's been done. And if you looked at that, you would say that unit has failed on its GIRF target. It may have done, but it's trying to think about whether this target is realistic for large units who are already doing large amounts of work. And I think the reason that I'm very keen that we talk about the incident population as well, is that this is the area where we've got an evidence base for. This comes from Peter Blake's work, which shows that if you've got well-functioning AKCC units, you've got a well-functioning catheter modality insertion pathways, that you can get around 33% of your population, you can support 33% of your population to start on PD. This is an evidence-based target, but it's really empowered by ensuring you've got good quality patient choice, not forcing people onto PD, but ensuring you've got processes that allow people to make an informed and sensible choice. What I'd also say is that if we moved in this model to starting a third of all patients onto home dialysis program, onto home dialysis starts, you would increase your dialysis starts from seven starts a month to 18 starts a month. And that actually would start to reduce your in-center dialysis requirement by over 100 patients over a decade. So you can start to see with this model and this simple Excel tool how you might start to help inform plans over the next decade. Just what else we're doing in London to think about how we support the quality of home dialysis is, I think Catherine has and the Midlands and Mark have led some very good work around peritonitis and how we address peritonitis. We have put peritonitis as something that needs to be in front of every clinical director, every operational manager on a quarterly basis as a marker of quality. Peritonitis is not just around keeping people trying to prevent bad things happening to patients. It's a marker of quality. It's a really good marker of quality of care in your dialysis, in your PD program. And that's not to say that the units where those rates are high are doing a terrible job, but we need to be doing better in our peritonitis outcomes. Some of that is around making sure there's enough workforce in place to support these initiatives and to support people at home. And therefore, it's about ensuring there's a wider visibility of peritonitis rates within units. Because we know that in the UK that we have poor outcomes compared to other units globally, and we need to do better. I'm not going to talk about our engagement with the root cause analysis work. Catherine's talked eloquently around that already, but it is an important part of what we're trying to do. We're also trying to think about how we ensure that we've got the right workforce challenges. And I think Josie is going to talk about training, ensure we've got training for the next generation of doctors delivering home dialysis, but actually getting the right nursing workforce, dietetic workforce and doctor workforce now is challenging. Defining what the right workforce is difficult. We know that nursing teams take on different roles from unit to unit, and therefore a simple ratio isn't always very helpful. But actually benchmarking data within the region and within units has been helpful in supporting cases for growth. And I think we can see here an abstract we presented at one of the UK Kidney Association, UK Kidney Weeks recently, showing that actually, even at a very simple level, peritonitis rates correlate to an extent with dialysis nursing workforce. If we haven't got the right workforce in place, we are setting ourselves up to fail. The other part that we've talked about today is about percutaneous insertions. I just want to recognise Brigu, who's Sood from St Helens, who's sitting at the back and is going to talk in a moment about his leadership in this area. We've essentially been supporting centres across the region to develop and maintain skills in percutaneous dialysis catheter insertion. We've got 3 units which have got very good percutaneous catheter insertion programmes, and Brigu has supported a number of units and is in the process of supporting guys to develop their percutaneous service again. And I think a success has been that in the last year, somewhere between 20 and 30 PD catheters have been put in advance through Brigu's mentorship and teaching, which has gone from 0 to 30. And I think this is a really good model, I think, of how networks can support units to train in percutaneous catheter skills. Many networks have a centre or two which have got these skills, and it's sharing it at a network level is important. Hilari's already talked about peer support, but clearly peer support and empowering patients, both in terms of making modality selection and already on dialysis who may be struggling with home therapies, is an important part of the sort of wider network quality improvement. So as I just keep an eye to the time, come to draw close, I hope you recognise that it isn't just about units and quality improvement. We need to be thinking about influencing the wider landscape in terms of what we do. I know there's a number of commercial partners, commercial fluid providers in the room. I just thought I'd share this. This is in the New Statesman this week, and it's just about how we can improve, work collaboratively with some of those organisations to improve advocacy of what we do. Many of you will know that the Labour Party conference is currently taking place. The view is that many Labour MPs read the New Statesman. This is an advertorial advocating for the fact that the NHS, that kidney care was not in Wes Streeting's 10-year plan. And then we've talked about 10-year plans for dialysis growth in London. It didn't sadly feature in the in the government's plans for the health service. And I think a strong, if you get a chance to read this, is a strong case for why we need to be growing home dialysis as the right thing for healthcare. I'm just going to finish with a picture. Growing sunflowers requires many things. It requires vibrant seeds. It requires enthusiastic farmers. It requires people who want seeds, people who want to grow and do home dialysis, but it also requires fertile soil. It requires watering. And I think the point about if we're going to grow home dialysis, it requires a landscape where all of us come together really to ensure that we get a fertile ground and that we can really grow home dialysis, both for those groups who believe in this, but also those skeptics and people who may not be in the room today. So thank you. I think what I hope I'm going to leave you with is this summary, which is that the challenge that we face and many units and regions face is that demand for dialysis is going to continue to grow over the next decade. And in London, we are almost already reaching the capacity for in-centre hemodialysis. To mitigate, growing home therapies has got to be part of that mitigation, and making the financial case is part of what we as regional networks should be helping support. I think delivering that GIRF 20%, as admirable as it is, Udin, I know you've talked very clearly about how that may be achievable in some units, is going to be challenging in the face for many units in the face of increasing dialysis growth. And that's why that 33% incident target is hopefully a really good way of delivering quarterly by quarterly quality improvement process. And hopefully I've demonstrated the GRIP 33 process, which we're rolling out across London, a model to really help inform units how to plan for the next decade to make sure that they've got adequate numbers of nurses, clinicians, and all the other resources required to grow home dialysis in the next 10 years. Thank you.